Yes. So, yesterday we started with the endocrines, है ना? So, where did I stop was a question related to this, and today we're going to start with this. That is your thyroid hormones. Yes. So, कल ये वाला question पे I had stopped. The hormone that requires to bound to plasma membrane receptor is what? याद आया? ये वाला क्वेश्चन पे वी जस्ट आंसर दिस क्वेश्चन और उसके बाद में we said we will continue. So today I'm going to continue with thyroid hormones. Yes, correct. So, and I told you that this question is related to the lipid solubility, right? This question is related to lipid solubility, and therefore only lipid soluble, I mean the substance, the hormone which is not lipid soluble is TSH. Therefore, it will bind to the receptors on the cell membrane. Now, let's begin to a very, very important hormone, that is our thyroid hormone. Yes, okay, just breathe. Hmm. Thyroid hormone. Now, first very important thing is the synthesis of thyroid hormone, right? Synthesis of thyroid hormones. So, the first step is taking iodine inside the cell. Taking this iodine inside the cell. And you can see that this is the sodium iodide symporter. Sodium iodide symporter, which will take the iodine inside. This step is stimulated by your TSH. Okay, this step is stimulated by your TSH, that is thyroid stimulating hormone. The second important one is this is going to be taken into the lumen. For example, see, this is the thyroid cell, and these are the follicular cells. Okay, these are the follicular cells, and inside this is the colloid. This is the colloid, and the thyroid hormones, they are going to be formed here inside. यहाँ पर form होंगे. So आप iodine को basolateral side से लोगे और अंदर लेकर आ जाओगे. Right? You will take them from that basolateral side towards the apical side. You will take them inside where the hormones will be formed. Now, the second step is iodination, oxidation of this iodine. Oxidation of iodine. So once you oxidize this iodine, it will get trapped, right? So you can see that this is the hormone peroxidase. Hormone peroxidase, which causes oxidation of iodine. The third step is iodination of tyrosine. Iodination of tyrosine. इसका मतलब जो टायरोसिन है, अमाइनो एसिड टायरोसिन, it will bind to iodine, right? It will bind to iodine and it will form monoiodotyrosine, monoiodotyrosine and diiodotyrosine, right? So there is iodination of tyrosine. This also requires the enzyme peroxidase. So second step, third step, enzyme peroxidase. Then the fourth step will be coupling. What is coupling? Monoiodotyrosine will combine with diiodotyrosine to form T3. T3 is triiodothyronine and DIT will couple with DIT to form T4. That is your thyroxine. Thyroxine. A very small amount of RT3 is formed. RT3, which is called as reverse T3, reverse T3, which is actually an inactive substance or an inactive compound. Now this thyroglobulin molecule, it will be taken or it will be having all of these: monoiodotyrosine, diiodotyrosine, T3, T4, reverse T3. They will be taken internalized. It will be broken down by the proteases T3, T4. Okay, T3, T4 will be then released into the circulation. T3, T4 will be then released into the circulation. एंड जो आयोडीन होगा MIT और DIT में, it will be removed by deiodenation so that the iodine can be recirculated. The iodine can be recirculated. Okay, so there are 3 steps which require peroxidase. First is oxidation of iodine, second is iodination of tyrosine, and third is coupling. And the enzyme deficiency can also result in hypothyroidism. Okay, the enzyme deficiency can also result in hypothyroidism. Then the next step is the binding proteins. So you must know that what are the binding proteins. The binding proteins are thyroid binding globulin, albumin, and thyroid binding prealbumin. Okay, thyroid binding globulin, albumin, thyroid binding prealbumin. Then my MCQ is that which is the major protein? It is your thyroid binding globulin. The TBG, which is binding 67% of T4 and 46% of T3. Okay? So the major thyroid binding globulin is TBG, that is thyroid binding globulin, which is the major one to bind with your proteins. Right? Next important one is, what is the difference between T3 and T4? What is the difference between T3 and T4? This is very important. So you must know that T3 is actually the active form that is going to bind to the nuclear receptors. Okay, it is the active form that is going to bind to the nuclear receptors to bring the actions. Right? Its half-life is very less, 1 to 2 days. 1 to 2 days. And T4, it is the transport form. It is mainly bounded to your plasma proteins. It is bounded to your plasma proteins, and it has got a half-life of 6 to 7 days. It has got a half-life of 6 to 7 days. So in the periphery, what happens? T4 is converted to T3 by the enzyme deiodinases. And this T3 will then act on the target tissues. Right? So you have got, T4 is secreted more in amount. More secretion is T4 and this is less. But in the periphery, T4 will be converted to T3 and you will bring about the actions. Now, most important action of the thyroid hormone are calorigenesis. It increases our BMR. Right? It stimulates the activity, the number of mitochondria, and also the sodium potassium pump, and therefore the BMR increases. Growth maturation, like ossification of the cartilage and bone, erythropoiesis, timely onset of puberty, lactation. It is very, very important in myelination, synaptogenesis in the CNS. It also increases the sensitivity of target tissues to catecholamines. Sensitivity of the target tissues, especially heart, to the effect of catecholamines. Right? So, most important action is thermogenesis, that is calorigenesis. It causes chemical thermogenesis, increases heat production. and myelination is very, very important. You should not forget them. Hmm. Now, the next one will be our, see here also you can see this, like growth and maturation of CNS, BMR, metabolism and cardiovascular effect. You can take this table also. Hmm. ठीक है? हाँ, 1 minute शिवानी, 1 minute. See, take this. Once you are done, let me know. Once you are done, let me know. Take the other one. Once you are done, let me know. Okay? Done? Yes. Good. Now see. This is again a detailed one. If anything which is left can be taken from here. How is the BMR increased? By increasing the sodium potassium ATPase pump, oxygen consumption, heat production, BMR, metabolism पे increase the glucose absorption, glycogenolysis, gluconeogenesis, lipolysis. Overall, it has got a catabolic effect on proteins. And hyperthyroidism will result in a myopathy, weakness in the muscles. Increase in cardiac output because of the upregulation of the beta adrenergic receptors. Like I told you that it increases the sensitivity of the catecholamines to target tissues. हाँ, मैं करती हूँ भाभी 7 बजे. ठीक है, बात हुई लेती हूँ. Right. Done with this? हो गया ये वाला? Now let's move on. Now, this can come as an image related diagram to us. Okay, corticosteroids, it can come as an image related diagram to us. So if you look into the adrenal gland has got medulla which secretes catecholamines. 80 to 85% that is secreted is epinephrine. Anuradha, it has direct role in infertility is because it also has got a role in the onset of puberty. And you see that most of the times the females who are hypothyroid or hyperthyroid, they have got menstrual irregularities. They come with oligomenorrhea, polymenorrhea. So it is definitely associated with infertility, 100% associated with infertility. It is not resulting in hyperprolactinemia. So thyroid is different and hyperprolactinemia is different. Both of them are different. Okay? But definitely thyroid disorders are associated with infertility. Is it okay, Anuradha? Okay. So the major secretion is epinephrine, which is 80 to 85%, and around 15 to 20% will be your norepinephrine. And I told you that norepinephrine is mainly a neurotransmitter and epinephrine is more of a hormone. Now there are three layers in the adrenal cortex. This is the medulla. Okay, this is the medulla and there are three layers in the adrenal cortex. What are the three layers in the adrenal cortex? GFR. GFR. Zona glomerulosa, fasciculata, reticularis. And if you see, maximum layer is this. 50% is fasciculata, 28% is glomerulosa, and 7% is reticularis. The enzymes which are synthesized are also specific. Zona glomerulosa is going to secrete mineralocorticoids, that is your aldosterone. Aldosterone. Fasciculata mainly secretes the glucocorticoids, that is cortisol. And androgens are secreted by the reticularis. Now remember, the androgens are not testosterone, it is androstenedione. Androstenedione. And dehydroepiandrosterone. Dehydroepiandrosterone. Right? So it is androstenedione and dehydroepiandrosterone. So remember, it is not testosterone. It is the adrenal androgens, which are androstenedione and dehydroepiandrosterone. हो गया? Now, next is the functions of your cortisol. Now, cortisol is called as a stress hormone, right? Cortisol is called as your stress hormone. जैसे मैंने आपको बताया था कि insulin is called as a hormone of abundance. It is called as a stress hormone. It is a hormone which is going to break down everything. Break down everything so that the body is able to deal with stress and there is adequate amount of nutrients which are present. So cortisol increases gluconeogenesis. It blocks the entry of glucose into the muscle and adipose tissue. Therefore, it causes hyperglycemia, glucose intolerance, and because of which the insulin level is increased and results in a steroid diabetes. Right? So diabetes can be because of pancreas, insulin is less. Diabetes can be because of excess of growth hormone, pituitary diabetes, or it can be a steroid diabetes, which is because of the excess of the glucocorticoids. Right? So hyperglycemic hormone and increases the glycogen synthesis in the liver. Increases the glycogen synthesis in the liver. Right? So write fast, and once you are done, just let me know, ma'am, done, like that. Okay, so that we can move forward. जैसे ही होती जाएगा मुझे बताते जाओ. The moment you complete, let me know, ma'am, it's done. जैसे ही होता जाएगा, let me know. Done with this? Done. Now next. Yes, next. Huh. Apart from your glucose, it has got effect on proteins. Proteins. It is basically inhibiting protein synthesis. Okay? It is inhibiting the protein synthesis. And it wants to release the amino acids so that you can use them for gluconeogenesis. You can use them for gluconeogenesis. So it inhibits the protein synthesis, release of amino acids from the skeletal muscles because they can be used for gluconeogenesis. It increases the urea synthesis. It increases the urea synthesis. Lipolysis. Lipolysis. And very important is it has got a permissive role for glucagon and catecholamines. That means it is going to increase the sensitivity of the hormone glucagon and catecholamines. So this is a very specific MCQ. A very specific MCQ that glucocorticoids has got a permissive role for which hormones? So permissive role for glucagon and catecholamine so that they can bring about their action. And breakdown of the contents is so that they can be used for gluconeogenesis. मतलब protein को amino acids में, fat को fatty acids में, so that they can be gluconeogenesis. Right? So whatever effects are very important, I'm highlighting them, and that you should know. Now there is also lipogenesis. Lipogenesis, but very important is the centripetal deposition of fat. You can see that in the Cushing syndrome, there is moon-like face and a centripetal obesity. So centripetal deposition of fat is a very, very important characteristic of your cortisol. Then large amount of cortisol, it is going to have decrease effect on the calcium reabsorption. It also inhibits the mitosis of fibroblast, degrades the collagen, predisposes to osteoporosis. This was also MCQ for you. ये MCQ था, ठीक है? Then wound healing is delayed because it decreases the fibroblast proliferation. It inhibits the anabolic effect of growth hormone. Large doses cause steroid myopathy. That means the muscle weakness. So the muscle weakness can occur also with excess of thyroid, and the muscle weakness can occur because of excess of the corticosteroids because they cause depletion of the proteins and they result in myopathy. Okay, they result in myopathy. Then over the CNS, psychoneural effects like irritability, depression, insomnia, and it decreases the REM sleep. Okay, it decreases the REM sleep, and you know that REM sleep is very, very important for your mental well-being, and therefore there is irritability and depression kind of thing with cortisol. Now it has got a, हाँ आकांक्षा एक मिनट बेटा, ये लो this one, ठीक है? Done with this? Before this? Yes, this much, this one. ओके ठीक है श्रुति, थोड़ा धीरे जाते हैं, ठीक है, धीरे धीरे जाते हैं, हो गया अभी, ठीक है. So decrease in the calcium absorption, decrease in the collagen synthesis, degradation of collagen, predisposition to osteoporosis. ये वाला inhibition of the anabolic effect, steroid myopathy. This was the slide you needed, Akansha? Done, ma'am. Done. Okay, come now. Now, this effect is very, very important. This effect is very important. It has got anti-inflammatory effect. So basically, it is anti-inflammatory, it is anti-allergic, and it is immunosuppressant. Immunosuppressant. It decreases bell. What is bell? It decreases the blood cells, that is basophils, eosinophils, and lymphocytes. Right? It is going to decrease basophils, eosinophils, and lymphocytes, and it will increase RBC, neutrophils, and platelets. And you know that this cortisol is very important in prolonged inflammatory conditions like arthritis. It is also important when you are going for the transplants. Transplants may, because it suppresses the blood cells, especially the lymphocytes, and it is therefore anti-allergic. Yes, very good, Akansha. It increases neutrophils also. Now it is anti-inflammatory because it prevents the breakdown. Okay, it prevents the breakdown to synthesize prostaglandins and leukotrienes. So usually what happens, the phospholipases, they break down the membrane phospholipids, है ना? And they will provide the precursors for prostaglandins and leukotrienes, which are inflammatory. But it is going to inhibit this totally, so that the inflammatory mediators are not released. It prevents the inflammatory mediators. You can also remember that it stabilizes lysosomes. It stabilizes lysosomes, so that the lysosomes, they do not break down. Lysosomes will have all the enzymes which are causing destruction, degradation. So it is also going to stabilize the lysosomes. हुआ इतना? श्रुति, आकांक्षा, हुआ बेटा? Done? Once you are done, let me know. Yes. Next now. Huh. Now answer this. Buffalo hump is seen with excess corticosteroid, excess aldosterone, Addison's disease, or immunosuppressive treatment. So you is with Cushing syndrome. You get this with Cushing syndrome. That is excess corticosteroid. Excess aldosterone is called as the Conn's syndrome. It is called as the Conn's syndrome. Yes. Done. Basil has given the first correct answer. Basil. So Basil को मिल रहा है tea and a cup of tea and sandwich. Basil का first answer था. Very good. Right? Next is action of aldosterone. What is the action of aldosterone? See, aldosterone basically is involved in the sodium reabsorption from everywhere where it can be lost. Especially first is from the principal cells, of DCT of kidney. Right? This is first one. It also causes the sodium reabsorption from colon, from the salivary glands, and also from the sweat glands. So everywhere where there is a likability that it can cause, that it will bring about sodium reabsorption. Anuradha has given the first correct answer. Very good, Anuradha. Yes, A. That is, Now, why does water reabsorption takes place? As it reabsorbs sodium, its main action is reabsorption of sodium. See, be very clear. ADH का main action is water reabsorption. ठीक है? लेकिन आपका aldosterone का main है action sodium reabsorption. Because sodium is reabsorbed, secondarily water is reabsorbed due to the osmotic effect. So it plays a very, very important role in maintaining your ECF volume, right? So main action is sodium reabsorption. जैसे जैसे sodium reabsorb होगा, water will be along with it. Remember that increase in aldosterone. Yes, this was an MCQ to you. Therefore, I gave you. मैं बताती हूँ आपको. ठीक है? मैं आपको बताती हूँ. Now, remember the regulation. There is CRH. What is this? This is corticotropic corticotrophic releasing hormone. Corticotrophic releasing hormone, which is coming from the hypothalamus, which is acting on the anterior pituitary. Anuradha now. Now see, there are two cells in the male reproductive system. One is the Leydig cells and the other are the Sertoli cells. The Leydig cells, they secrete testosterone, and they are under the influence of LH. The Sertoli cells, they secrete inhibin, and they are under the control of FSH. That means inhibin is inhibitory to FSH, or it is regulating FSH, and testosterone is regulating LH. So this becomes one MCQ, that LH ka regulation is testosterone, FSH ka regulation is inhibin. This FSH and LH are coming from the anterior pituitary, which is under the pulsatile secretion, not a continuous. There is not a continuous secretion of GnRH. If the GnRH is secreted continuously, what will happen? If the GnRH is secreted continuously, what will happen? It will suppress the androgens. So it is secreted pulsatile manner. Pulsatile secretion, and the GnRH is coming from the hypothalamus, that is arcuate nucleus. From the hypothalamus, that is the arcuate nucleus. Okay? So this is very specific, that FSH Sertoli cells actions of testosterone. Right? What are the actions of testosterone? Testosterone is very important for the pubertal growth. Okay, the pubertal growth spurt. The pubertal growth spurt. It helps in differentiation of the internal genitalia, that is epididymis, vas deferens, seminal vesicles. Now, as it causes the growth spurt, increases the height, it also takes care that there is cessation of the epiphysis. That means the closure of the epiphysis. But remember, the closure of the epiphysis is brought about more earlier by the estrogens. And therefore, if you compare male and female of same age, the height is comparatively more in the males, because testosterone इतना जल्दी close नहीं करेगा जितना करता है आपका estrogens. मैं देख लेती, तू कर. ओके, जब तक क्लास वर्क कर ले. Okay, then it brings about the spermatogenesis. फटाफट देख ले. It brings about spermatogenesis, very very important for spermatogenesis. Increase in the muscle mass, deepening of the voice, which develops in males at the time of puberty, growth of penis, seminal vesicles, and a negative feedback on pituitary. It also increases the RBC production, and it is also important in the intrauterine life for the descent of testis. Okay, descent of testis, also important in the intrauterine life for the descent of testis. So all the masculine features which develop at the time of puberty are under the control of testosterone. Done? This testosterone, a small amount of the testosterone is converted to dihydrotestosterone. Dihydrotestosterone. And this is with the help of the enzyme 5-alpha reductase. And there are certain actions which are specific for the dihydrotestosterone, right? So first complete this, फिर वो बताते हैं. So descent of testis, RBC production, negative feedback, internal genitalia growth. Done? Now, the specific actions of dihydrotestosterone are, you must remember this especially, the male hair pattern, the male baldness, the sebaceous gland, that is the over the face also, the increase in the activity of the sebaceous gland and growth of prostate. So, when there is a prostate hypertrophy in adult, okay, prostate hypertrophy, 5 alpha reductase inhibitors are given, right? So, dihydrotestosterone kahan se aata hai? Testosterone into dihydrotestosterone by 5 alpha reductase. And prostatic hypertrophy, when you speak of BHP, benign hypertrophy of prostate, 5 alpha reductase inhibitors are given. So, specific action of the dihydrotestosterone is growth of the prostate, male hair pattern, and the baldness which is there in the males, the male distribution of hair. Now, this question again on female reproductive cycle is very important. So, can we answer this? Estrogens and progesterones, they increase during which level? Secretory phase, decrease hai beta, okay, it is decrease. Secretory, ovulatory, proliferative, or menstruation. They are less in which phase? They are less in which phase? Anybody would like to answer? Okay. Or we will first understand the menstrual cycle and then you will answer. See, there are so many questions on this. बहुत सारे questions है इसके ऊपर. So we'll try to complete all these questions. ठीक है? D. Very good. Anurag, how do I say that the estrogens and the progesterones decrease? Now, when you look into the menstrual cycle, okay, your menstrual cycle, remember, if you start from this phase, that is menstruation, that means when there is bleeding for the first 4 to 5 days. The main cause of the bleeding is the withdrawal of hormones. That means there is no pregnancy, the corpus luteum has now regressed, right? Jesse, corpus luteum has regressed. What will happen immediately? There's going to be a decrease in the level of estrogens and progesterones. So as the hormones go down, there is vascular spasm and there is shedding of the endometrium during the menstrual phase. Then the second phase is your proliferative phase. In the proliferative phase, there is regeneration of the epithelium. Okay, there is regeneration of the endometrial cells or regeneration of the endometrium. Regeneration hoga uska usme. Development of the glands, the blood vessels. This phase is under the influence of estrogens, and because in this phase there is development of the follicles, okay, there is follicle ka development, there will also be rise of FSH, that is follicular stimulating hormone, okay. So FSH, LH is luteinizing hormone, this is follicle stimulating hormone, that is FSH. So this is the pre-ovulatory phase. It is also called as the pre-ovulatory phase. Then after the ovulatory phase, there is post-ovulatory phase. The post-ovulatory phase is also called as the secretory phase, under which you are preparing the endometrium for implantation. So every month the uterus thinks that there's going to be pregnancy and preparing the uterus for implantation of the fetus or the implantation of the ovulation product. So there will be glycogen deposition, blood vessels, they become more tortuous. Okay, the blood vessels become more tortuous. Glycogen, lipid deposition will be there. In this phase, there's going to be a rise of progesterone. So this is basically a phase of under the effect of progesterone, right? And LH surge जो होता है ना, it is only at the time of ovulation. And it is under positive feedback cycle. It is under positive feedback effect of estrogens. So the estrogens, they bring about a positive feedback effect on LH, and there's going to be the LH surge, right? So pre-ovulatory, ovulatory, and post-ovulatory. Now, if you consider your ovulation, obviously there is going to be increase in LH in the blood. There is increase in the basal body temperature. There is increase in the basal body temperature. This is called as the thermogenic effect of progesterone. Thermogenic effect of progesterone. The cervical mucus shows a fern-like pattern. Okay, fern-like pattern on microscopy of the cervical mucus. Cervical mucus. Okay, fern-like pattern. The cervical mucus becomes such that there is easy penetration of the sperm. So you look it and you find a fern-like pattern. And the cervical mucus can be stretched. The elasticity increases. This is called as the spin bucket phenomenon. Spin bucket phenomenon. That is the stretching and the increased elasticity. So the indicators of ovulation are increase in the basal body temperature because of progesterone, increase in LH, fern-like pattern on microscopy of the cervical mucus, is elasticity or stretchability, that is called as the spin bucket phenomenon. Okay, a spin bucket phenomenon. ठीक है, इतना हुआ तो मुझे बताओ. So pre-ovulatory estrogens, post-ovulatory progesterones, LH only during ovulation, and FSH more in the proliferative phase. So we are done with first answer. That is estrogens and progesterone's level, they will decrease during menstruation. Both of them are never increased at the same time except in pregnancy. Okay, they were never increased in the same time. हो गया इतना? Now, next question is, हो गया था बेटा इतना सबका? श्रुति, श्रुति हो गया था? Now, when do progesterones rise in their peak in female reproductive cycle? Immediately before ovulation, between ovulation and beginning of menstruation, during development of follicles, or when the blood concentration of LH is high. What will be the answer? Yes, good. मैम ने श्रुति को स्पेशली कॉल आउट किया. जब कॉल आउट करो तो यू बिकम मोर अलर्ट, है ना? चलो इसका आंसर दो अभी. नाउ आई हैव मेड यू क्लियर व्हेन विल द लेवल ऑफ हार्मोन्स राइज. ठीक है, तो प्रोजेस्टेरोन कब राइज होगा? ए बी सी डी. When will the progesterone level rise? A, B, C, D. Between ovulation and beginning of menstruation, immediately before ovulation, during follicular development, or when the LH is high? No? Basal. When the LH is high, it is ovulatory phase. Yes, Akansha, after ovulation. So A, ovulation and next menstruation. Ovulation and next menstruation. That means post-ovulatory period. Got it? Anuradha, very good. Basal clear हुआ बेटा? Basal clear हुआ? Yes, good Anuradha. Basal का clear हुआ? Doubt? Now see, This can come, same thing can come as a graph related question to us. Same, right? Graph जैसा question आ सकता है. Yes, good. हाँ. So, most potent aldosterone, deoxycorticosterone 130 as potent as aldosterone, corticosterone slightly. The synthetic one is the 9 alpha fluorocortisol. 9 alpha fluorocortisol, which is synthetic, but it is even more potent than aldosterone. Synthetic, but more potent than aldosterone. So, natural में it is aldosterone. ठीक है, हो गया? हो जाएगा तो बताना मुझे. Done? Now, moving next. Done? Now, what are the actions of the adrenal androgens? Actions of the adrenal androgens. Adrenal androgens, especially in females, are very, very important for libido, axillary and pubic hair growth. Axillary and pubic hair growth. Very, very important for the axillary and the pubic hair growth. So in females, the effects are brought about by the estrogens. But axillary hair, pubic hair, libido are the actions of androgens. और androgens हमने लिखा था dehydroepiandrosterone and androstenedione. We wrote those. Next. Now, which cells secrete testosterone? Which cells secrete testosterone? Anybody? So it is the Leydig cells that secrete testosterone. The Leydig cells that secrete testosterone. Now, how is their regulation of testosterone? This is very important. So, testosterone is, yes, very good. It is B ना, Leydig cell. सबसे पहला आंसर ठीक है. CRH coming from the hypothalamus acting on the anterior pituitary, which will secrete ACTH. This ACTH will secrete cortisol and also your aldosterone. Right? So aldosterone can also be increased by whenever there is increase in potassium or decrease in sodium or ACTH or angiotensin 2. Increase in potassium, decrease in sodium, increase in ACTH or angiotensin 2. All of these can increase your level of aldosterone. Okay? They can increase your level of aldosterone. So the main effect of aldosterone is sodium and water reabsorption. So mainly sodium reabsorption. Okay? Mainly sodium ka reabsorption. But potassium ka secretion. It also brings about the secretion of potassium. Okay, sodium का reabsorption, but also potassium का secretion from the principal cells, P cells. Okay, from the P cells. Now, this was an MCQ to you. इसमें आपको ना कैसा पूछा था मैं दिखाती हूँ. Yes, आपको पूछा था कि सबसे पोटेंट ग्लूकोकॉर्टिकॉइड कौन सा है. So remember cortisol Cortisol is the most potent glucocorticoid, having 95% of the glucocorticoid activity. Corticosterone, about 4% of the corticoid activity, right? Then next are the cortisone, prednisone, methylprednisolone, dexamethasone. Out of this prednisone, methylprednisone, dexamethasone, they are synthetic. So natural में it is the cortisol which is having the most potent glucocorticoid activity. This was a direct MCQ to you. That which is the cortisol which has got maximum or the most potent glucocorticoid activity. तो इसका आंसर था आपका cortisol. Right? हो जाएगा तब बताना मुझे. डन. सो कॉर्टिसोल, कॉर्टिकोस्टेरॉन, कॉर्टिसोन, ये तीनों में से सबसे पोटेंट इज कॉर्टिसोल. बाकी के तीनों दे आर सिंथेटिक. हुआ. नेक्स्ट. हाँ, डन. सो मिनरलोकॉर्टिकॉइड्स, sodium reabsorption, potassium secretion and hydrogen secretion. Okay, sodium reabsorption, potassium secretion and also hydrogen secretion are the effect of mineralocorticoids. Now see, this was the question. Which of the following steroid has got most potent mineralocorticoid activity? Most potent mineralocorticoid activity. So it is aldosterone. Aldosterone. Mineralocorticoid activity is aldosterone. So I'll make you write down the others also. So most potent is aldosterone. Aldosterone. Very good graph of the menstrual cycle. So आपको पता होना चाहिए कि pre ovulatory phase में there is estrogens and FSH. At the time of ovulation there is LH and after ovulation there is progesterone. ठीक है? So pre-ovulatory, post-ovulatory. If the same thing comes in the form of a graph, you should be able to answer, you should be able to recognize. And यहाँ पर इस peak पर there will be the thermogenic effect. So remember that x-axis पे अगर मैंने यहाँ पे temperature डाल दिया, okay? और आपको पूछा कि this is the thermogenic effect, मतलब इस time पर there is rise in temperature. So आपको क्लिक होना चाहिए कि this is going to be progesterone. ठीक है, this is going to be progesterone if I plot according to temperature. So this is one of the most important topic in the female menstrual cycle as far as the MCQ is concerned. Okay, so if you want to draw or if you want to take a photo, whatever you do, just keep this with you. Done? ठीक है, next. Now, capacitation occurs in, what is capacitation? Now remember when there is spermatogenesis, okay, the sperms acquire motility in the epididymis, okay, in the epididymis. Now, even after they acquire motility, further motility will be increased. Okay, there will be a further increase in motility. Further increase in motility and capacity to increase in motility and capacity to fertilize the ovum. Right? Further increase in motility and capacity to fertilize the ovum. This is called as capacitation. This is called as capacitation. ठीक है? This is capacitation. So, where will be capacitation? It will be in the female genital tract. It will be in the female genital tract. So, what is capacitation? Right? What is capacitation? Further motility increase hogi and capacity to fertilize the ovum, which is actually in the female genital tract. Done? Next. Now, what is the major function of HCG in pregnancy? What is the major function of HCG in pregnancy? So, the HCG is secreted by the syncytiotrophoblastic cells. In syncytiotrophoblastic syncytiotrophoblasts, and its main role is to maintain pregnancy. Correct. Maintain, support corpus luteum and placenta. The major function is to support corpus luteum and placenta. It is a hormone. It itself is a hormone. Akansha. It is a hormone. Okay, so it maintains pregnancy up to 3 months. Up to 3 months till placenta is fully developed. Okay, till placenta is fully developed. Once the placenta is fully developed, then it will itself secrete estrogens, progesterones. So major function of HCG is 3-month pregnancy, plus HCG will rise in urine. And it is going to be the first indication that a woman is pregnant. First indication of pregnancy. You do the UPT, the urine pregnancy test. The urine pregnancy kit, it actually identifies your HCG. Okay? It identifies your HCG. So the correct answer is A. That maintains the pregnancy up till 3 months. Okay? Next. The most important hormone to support pregnancy. Yes, good Akansha, good. The most important hormone to support pregnancy, obviously it is progesterones. They relax the uterus also. Estrogens, they increase the contraction. Yes, correct. Then you must know this. What are the placental hormones? Very good. Everybody has given correct answer. So, everybody should be, offered a treat for this. Very good. Correct one is by Anuradha. No, yes, by Anuradha. Good one. So, placental hormones are HCG, human chorionic gonadotropin hormone, which is secreted by the syncytiotropoblast immediately after fertilization, and it is detectable as early as 14 days after conception. First important role is diagnosis of pregnancy. Second, extends the corpus luteum and stimulates the corpus luteum to secrete testosterone. Right? So, this MCQ is important for you. It is a glycoprotein. Remember, it is a protein hormone. It is a glycoprotein. Then second important hormone is HCS, human chorionic somatomamotropin, which has got a lactogenic effect. Then estrogens and progesterones are there. Relaxin is a hormone that relaxes the pubic symphysis, the pelvic joints, and actually it facilitates delivery. It facilitates delivery. हुआ? Done with this? Yes. So HCG, HCS, estrogens, progesterones, relaxin. They are the hormones of the placenta or secreted by the placenta. हो गया? Now, I hope it was done. Once it is done, let me know. Because it changed now. Done. Very good.